So our next session is going to be more of an informal fireside chat between two very interesting women. One is Seema Srivastava, who embodies the power of community-driven health advocacy. Seema is the Global Advocacy and Social Impact Director at Beyond Type 1, where she works to expand diabetes care to over 2 million people globally and build strategic partnerships with international organizations like the World Health Organization, UN agencies, NCD Alliance, and others. She has held senior leadership roles at UNDP, World Bank, Aspen, PATH, and has dedicated more than 25 years to leading transformative change in global communities. Her passion for social impact and belief in collaboration have shaped her journey as a philanthropic leader, tackling complex challenges and driving initiatives that inspire collective action. The other is our own Dr. Nalini Saligram, the founder and CEO of Arogya World. She is an Ashoka Fellow, a TEDx speaker, and a tireless advocate for diabetes prevention. Under Nalini's leadership, Arogya World designs and implements scalable, science-based diabetes prevention programs in schools, workplaces, etc., and has reached 29.5 million people in the community setting over the last 15 years in India. Nalini leverages public-private partnerships and global platforms to improve the world in which we live. She led Arogya to become a 2022 recipient of the UN's Interagency Task Force on Non-Communicable Diseases and the WHO Award for Strengthening India's Primary Healthcare, and the Google AI for Social Good. Nalini and Seema, I'm going to pass this on to you now. Thank you.
Thank you. We're going to be 30 minutes late. So sorry, guys. It's 12 almost, and we wanted to end the session. This is the last one, though. But it's an important point. So thank you for indulging us. We've had such a fascinating morning. I really feel we've made some history here. And this is the beginning of a annual conference like this. We want to do this every year. I think we need to shine the light more on how South Asians are impacted and all these new things we learned today. And, you know, we just need to modify our own expectations of how we lead our lives, as well as what we can do to influence others as well. So Seema, I really look forward to this conversation with you. We're going to get directly into the topic, okay? We don't have time for a setup because we're already late. I want to ask you a few questions, particularly on the traditional role of played by philanthropy in healthcare. Okay, what have you seen as the traditional role? Philanthropy has a role and has played an important role, but what do you see?
I'm not going to use a mic. I've never used one in my life unless there's more than 150 people. So I'm just going to speak without one. I will moving voice. But traditionally, what I've seen is that philanthropy really steps up where systems fail or don't fill the gaps, like funding innovations or reaching underserved populations, or in governments where governments are slow to respond in taking risks. But I do see a shift that is happening over time, where traditional philanthropists are moving away from just filling gaps towards actually funding more systemic spending, right? In type 1 diabetes, which is where my primary work is, it is not, it's lifelong. It is not preventable. So this means increasing access to insulin, to technology, to ensuring that the capacities are built of community health workers and primary healthcare workers to be able to deliver care. Also in long-term programs that can see better outcomes for those living with diabetes. So definitely the shift is more needed and it is coming. I will try.
Okay. So I wanted to add a bit as well. I have been in global health for some decades now, and I have watched several phases of global health: HIV, AIDS, women's health, sexual and reproductive rights, under 5 childhood mortality, all these have been waves of global health that I have actually been able to witness. And what is very interesting is that philanthropy did step up and tackle all those really serious challenges. Okay, just to give you one example, Gates Foundation, definitely made a difference, even in deep remote states in India. It has made a difference to the way women's health is tackled, the way under 5 childhood mortality is tackled, HIV is tackled. This stuff, it does happen. Individual philanthropists can make a difference. What is very interesting now is that I feel technology and nutrition are also coming into the play. Those are also spaces that are being attractive to philanthropists. So it is very interesting. I think diabetes less so maybe, but several aspects of global health are covered by philanthropists. So to diabetes now. For an issue that is so community centered and affects so many of our families so deeply, why has diabetes been chronically underfunded despite the scale of the crisis? You go ahead and I'll add some color.
Well, so diabetes is not a scale problem. It's a visibility and a stigma problem. 589 million people live with diabetes in the world. It causes 1 death in every 9 seconds. Almost more than 1 trillion global health cost on diabetes. And only less than 2% of development assistance in health goes in NCDs. So really, it is not the lack of resources that is the key for it, right? Part of it is, and I've been hearing all of this, and it's quite a lot about type 2 diabetes, is the basic feeling or framing of diabetes as one size fits all and saying it's manageable, right? To really understand that it's manageable only if you have the right tools, the right technology, the right medication, the right training, and the right support system. We leave out a huge thing that was mentioned about the diabetes distress that people live with. And let's be honest, even for most of us living in privileged communities, it is a daily burden to manage diabetes. In India, where it's got the maximum number of children living with diabetes. Over 300,000 live with type 1 diabetes, and they still don't have access to medication, access to resources. And I'll give you an example. So, and this goes back to what you mentioned about the Gates Foundation. I used to lead the Gavi program for them in India. So really seeing this very closely. About last year, we got an application from a very small nonprofit working in a district in Jharkhand. And what struck me and sprung out to me was it said, one, that they worked in integrated health, and so diabetes, cardiovascular. They said, the one line they said was, they want to work in this little district called Pakur because nobody believes that diabetes happens to people in villages. It is a rich thing, and it should only be if you eat well, which none of the people rich people do, is in the interviews that they send to us in the need analysis. That is what is going to happen. Now, over 17,000 people in this little village there, we funded them, and 1,700 came out with diabetes, some at dangerous levels of diabetes, and 111 with type 1 diabetes, of which there was a girl of 7-year-old going into DKA, right? And look at this. To get them diagnosed, she had to work with the government to get 2 blocks to set up a system where 85% of them did not have national identity cards, so could not get insulin or access to insulin. There was not even an auxiliary nurse or midwife going into that district. And so they had to take them to Bengal border in Malda to a primary healthcare center for this girl to survive, which is 38 hours away, through 7 modes of transport. Right? So it goes back. And now that we have given them the funding, industry in India has given them support. I'm sure many of you know that the national guidelines for diabetes in children has just been released by India, where You can get free insulin testing. But the reality is far from that, right? Um, so the lived experience is very important in all of this.
Yeah. So I just wanted to say that, the Global Burden of Disease report says these non-communicable diseases, NCDs, she used the word, which includes diabetes, heart disease, cancers, and chronic lung diseases. These diseases are the number one cause of death. I mean, there's just, it's a keeps on coming up. One, two, three reasons for dying are these chronic diseases. Diabetes is not always recognized as a very serious disease. Okay, it does have very serious complications, though. You get heart disease, you get stroke, you get foot amputation, you get eye disease. All of these are complications of diabetes that is not fully appreciated by even governments, which is why there is so little action for preventing this. At the same time, prevention is the smart solution to this crisis. Okay, we know 80% of type 2 diabetes. Dr. Kanaya is not here. Oh, there she is. I don't know about South Asians, but 80% of type 2 diabetes, DPP, WHO, a whole bunch of global landmark studies have shown you eat right, you exercise, you avoid tobacco, you can prevent 80% of type 2 diabetes. And that's 90% of the disease burden, okay? And you can prevent 80% of heart disease. Also of great interest to us in South Asians here. So if prevention is the smart solution, why is there so little interest? 1 to 2% of development assistance goes to prevention, okay, in the world. It just defies logic. Number one cause of death. Global studies show that it's possible to prevent, yet you can't prevent. There's no interest in preventing. 1 to 2% is nothing, almost nothing. So we today have an opportunity to call for more action on prevention. And the one reason is the pharmaceutical companies, for example, don't want to invest in prevention because they want to grow the pie. They want more people to get their medicines, perhaps. So, but we need to get lots of stakeholders interested in prevention, even though the outcomes are not going to come for 20, 30 years. Even though you can't see, you can't put your arms around what prevention really looks like. I think that's one of the biggest challenges we have. One is the narrative. One is for me, people to understand that diabetes is very serious. And two, to understand that it's underfunded by everybody. And three, to understand that there is hope. You can do something about it. It's called lifestyle change, even though the jury may be out on South Asians for a little bit. Hey, I think fundamentally, eating right and exercise and sleeping, all these are really, really important, and we must make that happen. So lots of challenges for us. Okay. I just want to take 2-3 minutes more to understand a little bit about what the Beyond Type 1 does. Okay, and then I want to tell the audience here what Arogya World does. Hey, all morning today, we haven't had much interest or it hasn't come up, so I do want you to know what we do. Okay.
Before I just talk about Beyond Type 1, let me just start with the premise that you said about prevention. And Beyond Type 1, and we are called Type 1, is because that is how we were founded, because our co-founder, Nick Jonas, lives with Type 1 diabetes. And it was co-founded 10 years ago by Nick Jonas and Julia DiPagani. And Type 1 diabetes is not preventable. It's lifelong, and it's chronic, and it needs to be managed very, very seriously. So really, it was two powerful ideas on which it was founded. The first is that anyone with diabetes should have a life beyond that diagnosis. And the second is it should not be alone. So we really believe that anyone who lives with diabetes deserves the right to have access to care, to knowledge, and to have a full life, so that they can survive and they can thrive. We work across both type 1 and type 2 diabetes. So we do have a Beyond Type 2 as well. And our whole model is based on a combination of storytelling, on digital tools and reach, on educational resources, political advocacy, and community. And I heard before me, the professor from San Diego talk about community, very, very important for us, and peer networks. So why we are unique is that we don't believe that awareness is the end goal. It is the beginning or the entry point. And our digital reach, which is over 600 million people, is what we use to build awareness. Our community, which is almost 5,000 ambassadors of living with diabetes, are how we build trust, we build action, and we build community and peer support. I heard someone ask, who will be your quarterback? It is your community who will be your quarterback. So we have this 5,000 community who then translate these resources into absolutely contextual, simple languages and toolkits, which then go into the community through our ground of our programs. So our programs in the US are called Beyond Barriers, and we really are closing the gap in care for those with type 2 high incidence of that, and especially in the brown and black communities. And then in also working with those in misdiagnosis or lack of diagnosis in type 1 diabetes. I lead the international work for Beyond Type 1, and I will speak specifically for India. In India, we give a lot of grants to very grassroots organizations that work to build awareness, educational resources in very innovative and creative ways to reach the last mile. We then also do political advocacy, and we built an ambassador network which can go into deep into the community to really talk about type 2 and type 1 diabetes. That really is the core of our work. Just to give you an example, last year we launched the Beyond Type campaign in collaboration with our board member Priyanka Chopra Jonas, and Priyanka's reach helped us reach 450 million people with that campaign, and translated our work to 3 million people in just 9 months on ground, by just the reach that we have. And this is really because of the culture, the community, and the partnerships we build on the ground.
Yeah. So just to give you a flavor of what Arogya World does, we do diabetes prevention through healthy living in India mostly, and we've just pivoted to bringing some of our learnings to the US. We work in the community setting, translating the science from these big landmark studies into on-the-ground programs that are effective and well-designed and work. We've reached 29.5 million people through last year, over the last 15 years. We work in schools, in workplaces, we work through social media, reaching urban consumers where they spend time on Instagram, teaching them what to eat and in what quantities at every meal. We have schools programs where we teach school children the basics of healthy living. What is the importance of eating fruits and vegetables, and we use them to get their families healthy as well. So we're getting traction there in all these programs. We do behavior change. In fact, with Stanford Care, we have published a paper that shows data on the pre-post effects we are seeing in life behaviors of these school kids. These are school kids in rural settings in West Bengal, in Uttar Pradesh, and Rajasthan, and we are getting really good results. We also have a workplace program where we certify companies as healthy workplaces when they reach certain employee health criteria for program criteria in physical health and mental health, and we require them to recertify every 2 years. So 300 companies reach of several million employees is what we have in India. I think we're encouraged by all the feedback we are getting from our partners as well as from these company CEOs and HR leaders. Big companies like Godrej and Tata Consultancy Services and Indian Oil and Bayer and Reliance have become what we call a Hall of Fame healthy workplaces. These are at the top of the heap. They're ambassadors. They believe in our program. We are not a vendor. We are a knowledge partner to all of these companies. So we are on CII, Confederation of Indian Industries, top, public health councils. We also have made As I said, we use Instagram to educate people on my thali, which is what to eat in every meal and in what quantities. Cooked food, again, we go with the cooked food. Today we saw an example of that. And then the last point is entire cities. We make them healthy cities. We call them Arogya cities. We mobilize Bangalore and Mysore have become healthy Arogya cities. We are now in conversations to do that in Bombay and Chennai as well. We're also pivoting to the US, and we're finding our schools programs that were designed, yes, for 11-year-olds in rural schools in India are working here in the US. We have adapted that same program, and it's called Arogya Clubs, to deliver, use high school students to deliver our program to 11-year-olds, Hispanic and African American kids in vulnerable communities in Atlanta. And we've just finished 1-year program. So there is interest in expanding it to the rest of Atlanta. There's also interest to expanding it nationally. And we're going to, take it up. Here, the South Asian Heart Center is a partner of ours, and we are bringing that same lifestyle change program of theirs to our communities. We have communities in Chicago and Atlanta that they don't have access to. So hey, nonprofits partnering with other nonprofits is fairly disruptive, okay? It doesn't happen every day. Everyone has their own lane and silo, and I am very excited that we are beginning to make those changes happen. We also have a tool here called My Desi Plate that shows people, and Ashwini was part of it, and so was Minal. We are looking at ways to what do you eat when you eat Indian food and you're an American? Hey, we'll show you what to eat, in what quantities. And we have that, it's on our website. We promote it every year. So I also want to ask you, we're in Silicon Valley, Seema, there's incredible wealth here. There's incredible wealth among South Asians here. And I wanted to ask you, what is the role that diaspora philanthropy can play in prevention?
Well, also in funding long-term care. Well, so the diaspora actually really sits as a South Asian who's living with diabetes since the last 15 years, has gone through the entire stigma, misdiagnosis, misconceptions, advice to lifestyle, not giving importance. To me, I see the diaspora really sitting at a very important intersection where there's capital, as you just mentioned, there's professional expertise, and then there is cultural fluency and understanding. Right? And this cannot be replicated at all. Cultural fluency is important because a health solution designed in suburban America cannot apply to the Indian subcontinent. Let alone the urban. Rural is very far from that, right? And this is where the diaspora plays a very critical role. First, in advocacy. So you mentioned, things like the healthy plate and people working in silos. When I walked in, and this is after 25 years of working across 60 countries and a lot of it in India, most nonprofits work in silos. So, advocacy and working as an ecosystem is the first thing that the diaspora can do for us. The second really is, in the funding. So for type 2 diabetes, it would be a very fair ask to say fund prevention models, right? But type 1 has a different urgency, right? And is greater because people are struggling to access insulin, struggling to get trained care, and to find support in community to beat the social stigmas, the social influences, the family dynamics, the diet, all of which the diaspora understands really well. And that is where we need the diaspora to come together to fund these models of long-term care, not to do one-time charities, but to think about long-term care and lived experience solutions. So there are a number of our organizations like Arogya World and us. We came together because Nalini approached us with some of the tools that they have launched in Instagram. We are a highly digital organization. We get a lot of funding, and I also sit on the advisory of a $100 million fund of Aligned T1D, which is, of course, T1D is what it's working for, but it's industry partners like Roche, and it's Lilly and Novo and Hemsley and Breakthrough, which all are coming together to fund LMIC work for type 1 diabetes care and long-term support. And we are looking to Arogya for their invention that they had, or the innovation in a WhatsApp, because India is the WhatsApp queen of the world, right? And how do you get information out easily to people in very simple languages? So really, where you're born should not determine your diabetes outcome, and that is where diaspora can help us fund these models.
Yeah. So, coming back to the wealth of our community and of Americans in general. So, Indian Americans have, are at the peak of their achievements. People do really well here. They are, business leaders. They are philanthropy leaders, and they are stepping up. What was it? Dalberg did a study of 2 years ago, and then they compared results to 5-6 years ago. And Arogya World, we are members of the India Philanthropy Alliance, and the last round was in collaboration with IPA. So what it showed is that Indian Americans are giving, over those 5-6 years gap, they tripled their giving. Okay, so they used to give at $1 billion when the Americans were giving at $5 billion levels, individual Americans. But now Indians are giving at $4 to $5 billion level. Okay, so they tripled their giving in 5-6 years. I think that's very encouraging. Okay, you're not just at the peak of your business achievements, you're also stepping up. I felt, that, hey, we are stepping up and we're doing a lot even in philanthropy. So the gap is still there. We're still $1 billion behind what average Americans would give. But if we started giving at those levels, we would, be quite a force. $85 trillion is $84 trillion in wealth is intergenerational in the next few years. So we really need to capture that. A good part of that is going to be Indian Americans, and I think we can really make a case for, hey, find wicked problems where you can, get some long-term outcomes. This diabetes is one of them. It's a space that is underfunded, as we have said, and this is a spot where you can make a difference.
Nalini, if I may just add
Yeah.
to something that you just said, is while the funding that has increased by the Indian diaspora, what is missing is the integrated funding and focused funding. So even today in diabetes, the largest funding doesn't come from the Indian diaspora, when it is the diabetic capital of the world, second largest diabetes, highest number of children living with diabetes. The South Asian community is known for the diabetes. I mean, I work in projects in India and Africa, especially India, keeping it to India. A large amount of projects of research are through Stanford and through funders, which are American billionaires, not at all by Indians. And that is really a good call that you're making is, we can help tell you where to invest if you would like to know.
So last question, 30 seconds, please, Seema. What do you think a transformational prevention model would look like where individual philanthropy can really play a role?
I think the first thing is to ask a question is, what does success look like for you? So what is the outcome that you personally, as an individual philanthropist, align with your personal need or your personal goal of your organization that you are with? What does that look to you? And then define success, because success is not, in diabetes, is not one size fits all, right? So for type 2 diabetes, I'd again go back, it's reduction in incidence. So investing in reduction in incidence, because it's high. And look at South Asian risk profiles. I saw a beautiful presentation earlier by Dr. Here. And so look at that and see where you can invest in that. In type 1 diabetes, you cannot reduce incidence, right? It is autoimmune. So what is it then? So then let's look at long-term models of care where access to insulin can be increased, where systems can be strengthened. India is one of the first countries to have taken out a policy that every public healthcare center will have test strips and insulin. Is that really happening? Right? We work closely with the William J. Clinton Foundation. It's only in 2 states that it's happening, right? So really, global commitments exist. The UN political declaration in 25 said that by 2030, 80% of the public healthcare facilities are going to have essential NCD medications, right? The gap is in delivery. And that is the gap that transformational philanthropy really needs to be catalytic in filling. And I have really two things that one should think about: activity versus accountability. So look for accountability, don't fund an activity. That is the first request to you. And the second is build models, fund models, capacities, which have long-term outcomes, not just a short filler gap, which is what most Indian philanthropists do.
So let me add my wish list to that. Unrestricted multi-year funding goes a long way to help the nonprofit world do what they can do best. Okay, so the McKinsey Scott model give a maybe not episodic but long-term funding, and then let the nonprofit decide how to use it is going to be a very good model. We, as I said, Arogya World, we are members of the India Philanthropy Alliance. They are experimenting, that coalition is experimenting with collective giving. I think that's a terrific idea. If we can join hands with other philanthropists and do it together, I think that makes a lot of sense. Collaborating on the ground in India for impact makes a lot of sense. So for me, one of the best ideas, someone came up to Arogya World and invited us to join, it is really fantastic. They're collecting a group of diaspora philanthropists here, but they have partnered with the government of India to find aspirational districts where a bunch of different nonprofits can do what they do best. So they can lift up the health and the education and the livelihoods of that one village or 10 villages, and that's works with the government of India's priorities as well, and it solves a lot of the regulatory issues that make all of us work harder than we should. But it is really a great model where there is on the ground work funded by philanthropists but in a coalition, so and where somebody else will ensure that the government is involved and that the programs get done, and there's accountability, not just activity.
Love what you just said. So I happened, since you brought it up, I happened to be part of the Mission Karmyogi. It went from my desk. So when I was with the UN, I was posted in the ministry in the South Block, and which is the Prime Minister's office, and we designed that Mission Karmyogi, which is identifying the districts, the priority districts for investment, and health and education was the core focus in that. When Mission Karmyogi came out, it was really not just to see the competency-based, a placement of government officers, but to get them and identify nonprofits which are doing fantastic work at the ground in different states, so that the government could partner with them and give funding without having them to go through those windows of procedures. So really a great point brought up by Nalini is look for those nonprofits who are doing great work. You will not go through the regulatory hassles. You will have no silo giving, but collective giving. And really, diabetes is the mother of all problems right now. So
anyway, thank you very much, Seema. Thank you.